Well, hello and welcome to the first episode of the Healthy Skeptic MD podcast. My name is Dr. Michael Hochman. I am a primary care doctor, a former health journalist, and author of the book 50 Studies Every Doctor Should Know. Since this is the first episode of the Healthy Skeptic MD, I will mention that the purpose of this podcast is to take a deeper dive into health news through interviews and discussions with experts and even in some cases patients. If you do like what you hear today, check us out on whatever podcast program that you listen to and subscribe, Healthy Skeptic MD. Now I have a great first guest today who I'll introduce shortly, Dr. Brad Spellberg. However, as I plan to do each week, I'm going to begin by giving you a rundown of the health news, and not surprisingly, during the COVID-19 pandemic, a lot of it will focus on that. So let's start out with the health news. Okay, so let's start off by talking about what's called convalescent plasma, which is basically the antibodies from someone who's recovered from COVID-19 and injecting that into somebody else to help their body fight the infection. Now, last month, the FDA provided what's called an emergency use authorization so that doctors could use convalescent plasma, but because the data has not been as strong as many had hoped, many experts have criticized this decision, and just this week, an NIH panel came out critical of this. So the NIH panel concluded there are currently no data from well-controlled, adequately powered, randomized clinical trials that demonstrate the efficacy and safety of convalescent plasma for the treatment of COVID-19. There are insufficient data to recommend for or against its use, and it should not be considered the standard of care. So basically, the NIH team is not convinced of the benefits yet and believe that more study is required. We'll talk a little bit more about this with Brad Spellberg, but I wanted to bring it up since it's something that you very well may be hearing about in the news. On another topic, there's been more conflicting data on children and COVID-19 and the impact of reopening schools. So on the plus side, there was a new CDC report from Rhode Island that identified that the COVID-19 infection had spread in just 4 out of 666 childcare programs that opened in the state over the summer. Now, the CDC report credited the success in Rhode Island to public health measures such as mask use by teachers and staff, reduced class sizes, and enhanced cleaning protocols. Now, studies also continue to demonstrate that children do not tend to get severely ill from COVID-19. However, on the negative side, contrary to initial reports, studies are now consistently showing that children of all ages do get the disease and can transmit it readily if effective preventive measures aren't taken. And in fact, last month, Israel had to back off on its school reopening plans following a disease outbreak there after schools opened. A growing number of districts in the U.S., including those in New Jersey, are also shifting more and more to away from in-person school reopenings. Okay, another big headline with COVID-19 this week is that we are starting to get the first reports of confirmed COVID reinfection. So public health experts in Hong Kong and another group in Nevada have actually demonstrated quite elegantly that the same patient in both of those locations have been infected multiple times with COVID-19. They were able to prove that it was a separate infection the second time around by conducting viral RNA sequencing and demonstrating separate distinct infections within the same person. Now, this, of course, is not good news. Still, it's what many public health experts had predicted. There are very few infections for which there is 100% immunity. So this is what many people expected. It is not reason to panic. Nevertheless, there's still some very important questions to be answered. We want to know how frequently such reinfections occur, and if during the second or subsequent infections the disease is any different. Is it any less severe than during the initial episodes? Another concerning study, this is looking at rates of depression before and after the COVID pandemic. This is from a JAMA, Journal of the American Medical Association study. It suggests that depression rates among adults may be as much as 3 times higher than they were prior to the pandemic. This is particularly true for those with lower socioeconomic status and fewer resources, and perhaps not surprisingly, particularly among those who experience stressors such as a loss of a job. So this really does highlight the downsides and economic and other social consequences of the pandemic and keeping the economy shut down. But I did want to end on a positive note before we get to Dr. Spellberg's interview. An analysis by researchers from Harvard Medical School and the Cambridge Health Alliance, both places where I have previously trained, found that Massachusetts healthcare workers since mid-April have been less likely to get serious COVID-related complications. Now, there's many potential reasons for this. Some have suggested it's because healthcare systems, doctors, nurses are getting better at treating COVID-19. Other reasons that have been suggested are simply that the virus may be attenuating. After all, that's how the 1918 Spanish flu pandemic ended, and many other pandemics in history, is just the virus weakened over time, which is something that not uncommonly happens. Our guest today has another theory about there, which we'll get into, but the authors of this particular study thought that maybe it is just that the virus is starting to attenuate, which regardless of the reason, the better outcomes is certainly good news. So that will do it for today's health news. Now let's transition over to our interview with Dr. Brad Spellberg, an infectious disease expert and a chief medical officer at LA County USC Medical Center, to find out what's going on with the COVID-19 pandemic. All right, so for our inaugural episode of the Healthy Skeptic MD podcast, I'm really honored to have my friend and colleague Brad Spellberg, who is the Chief Medical Officer of LA County USC Medical Center, which is the largest public hospital in Los Angeles County. Brad has also been on the front lines. LA County Hospital has seen some of the most cases here in California. In addition to running a hospital, Brad also happens to be a nationally renowned infectious disease specialist who has testified in front of Congress. He has written books, including what we'll get to later today, which is a great new book on the healthcare system, Broken, Bankrupt, and Dying. So looking forward to hearing a little bit about that shortly, Brad. Now, Brad told me when I was getting ready to introduce him to keep it simple because he is a simple man. So I will say quite simply that Brad is truly one of the smartest people I know, and I am very confident enlighten us about what's going on with COVID and where we stand. So very lucky to have Brad here today. So Brad, before we get into the meat of the interview, can you just tell us what it is like to be the Chief Medical Officer of Los Angeles County Hospital?
Well, every day is an adventure. As you highlighted, this is one of the largest public hospitals in the United States. And every day you come in and there's some issue that needs to be addressed, and you're always trying to make things better and look forward to the future. So it's a great adventure and it's a great honor is what I would say.
Now, have you been a little busy over the last 6 months?
Just a touch busy. We had this thing you may have heard. I think it's called COVID. Maybe you've heard. Yeah.
A virus, maybe?
Yeah, something like that. We've had more, as you alluded to in the introduction, we've had more COVID cases than any other hospital in Southern California. I think actually maybe even in all of California. About a month ago, things got very, very scary. And we really we actually really did hit the point where we were out of ICU beds. Now, fortunately, things are really slowing down in LA County now. And so we're off our peak. We peaked at about 120 COVID positives in the hospital, about 45 in the ICU. And we're down to around 45 to 50 total in the hospital and about 15 in the ICU. So a lot more happy, a lot more comfortable now.
And there's about 600 beds in the hospital, Brad? So 120 out of 600, it's a pretty sizable number.
Yeah, about a quarter of the beds for COVID positives, yeah.
Well, before I get into the COVID questions, because you said you're a simple guy, I will mention the first project that we ever worked on together, because I think it highlights your simple brilliance. Is Chief Medical Officer of LA County Hospital, you were concerned that patients were getting weak and debilitated lying in bed all day. And you had an elegant idea for how to fix that. And so tell us a little bit about that.
Well, boy, walking down memory lane, and you absolutely did help us with that. So the idea was that for whatever reason in medicine, when you go in the hospital, we tend to view the bed as the center of the patient's experience in the hospital. And so whereas at home, the person might get up and walk around, or they might sit up, they might read a book, they might get up, go to the bathroom. We tend to bring everything to you in bed and say, well, if you're in the room, you should be lying in bed. And we wanted to flip the script on that and say, you should only be in bed when you're trying to sleep. If you can get out of bed, you shouldn't be in bed. Even if you're not walking, go to a chair in the corner and sit in the chair. We want to start mobilizing people to decrease that debilitation, decrease that loss of muscle mass and the weakness that prolongs length of stay, leads to bed sores and all the other adverse events that it causes.
Great. Well, I'm still really looking forward to seeing if that simple solution can be proven to work. And I just thought it was a very creative idea, regardless of how it turns out. So Brad, what I want to do now is go back to the beginning of 2020, so March, February, January period, and just ask you, when did you realize that COVID was going to be a big deal as it is? And I'll have to admit that, maybe I should have known better. It took me a little time to sort of clue in that this was going to be a big deal.
So at the beginning of March, my terror was that I didn't know the answer to the question you just posed. That I'm in charge of the medical aspects of this giant public hospital. We are part of a system of healthcare in LA County that's the safety net for the largest county in the United States. And nobody knew the answer to that question, in part because nobody knew where COVID was. Is it spreading? Is it not spreading? And we had no information. And so people were talking about contingency planning. And my response was, how can I possibly contingency plan when I have no idea if it's here, and if it's here, how much is here, and where is it spreading, and how far away is the tidal wave if there's a tidal wave coming? And so, at that point, testing was really hard to get, and the system really wanted to intensively reserve testing for super sick patients going to the ICU. And I made the argument, I called my boss, Hal Yee, who's the CMO of the Department of Health Services, and I said, Hal, we cannot contingency, this is like trying to fly an airplane without instruments. We cannot contingency plan if we have no idea where the virus is. And so I begged him to give me permission to divert testing resources to the outpatient setting for mild influenza-like illnesses so we could get a snapshot, just a snapshot of people coming to our ER in urgent care, mild flu-like illnesses. Are any of them COVID positive? And he saw what I was getting at immediately. And a lot of people in the system were very concerned about this. And everywhere else in the county, no one was doing this. Everyone was preserving their tests for the ICU. But Hal stood by it, stood behind the idea. We ran the study. That ended up getting published in JAMA. And I think that the information, this was done in partnership with the Department of Public Health. Some very smart people at Public Health had wanted to do exactly what we proposed. They actually had a private hospital system in the county lined up to do it. And at the last minute, that system backed out because they didn't want to become known as the COVID hospitals. So when Hal connected me to Public Health, they're like, oh, that's exactly what we want to do. We need a hospital partner. So it aligned perfectly. And when the data came in, it really informed the public health folks that we needed to lock down the city a lot earlier than would have otherwise happened, because they began to see it was widely spreading and we didn't even know it.
And what did that study find?
So it was an evaluation of 4 days worth of healthy people, nobody. So these were not people that had any known exposures. They were not people who had traveled to an endemic area. There was no reason to think any of these people had COVID, but they had come to urgent care or the ER with a fever and a cough or some mild influenza-like illness. And we found that 6% of those people tested positive for COVID, which meant that 6% may not seem like a lot, but remember, this is the first, second week of March. That meant that earlier than anyone realized, it was widely spreading through communities to people who had absolutely no risks for it, which means they were passing it along to many other people without even knowing it. And when you look at exponential spread of a virus, that means the tidal wave that people said, is there going to be one? Yeah, it's a lot closer than we realized. And I actually think the difference between LA and New York was 1 week. If we had closed down a week later, when you exponential spread over that week, we would have ended up like New York.
Well, I certainly remember, Brad, when your study was published, it got a lot of attention, and it really, I think, caught a lot of us off guard because certainly primary care doctors like myself, in early to mid-March, we were not thinking COVID for patients with flu-like or cold-like symptoms. We knew it was a threat coming along, but we didn't think that any of our patients would actually have it. So I think that really caused us to take the situation a lot more seriously.
Yeah, and us as well in the hospital. We're like, oh, wow, we have a big problem here. Yeah.
Brad, another thing that has really puzzled me as a primary care doctor is just how variable the response of different patients has been to this virus. So the vast majority of my patients in my primary care practice have very mild disease, cold or flu-like symptoms. But I've had some people who are hospitalized. I even had one patient who had a number of chronic medical conditions die from COVID. And I just have had a hard time wrapping my mind around why people respond so differently. And I was curious if you had any insights or if the data is telling us anything about why that is.
Well, I guess I would start by making a general comment that this diversity of outcome is actually not that unusual for infections. And we actually see this in the laboratory as well. If we infect mice, for example, with various types of pathogens. And for many types of infections, the range can be mild to deadly. I think there are some factors that have been very, very well delineated for this virus, SARS-CoV-2, the virus. In patients, it's very clear specific comorbidities are the drivers of outcome in many patients. Age is the biggest risk factor, although having said that, we've had people in their 90s do just fine. And we've had people in their 20s die. So, but on a population basis, age is probably the biggest predictor of death. I will tell you that diabetes very frequently comes out in studies. In our experience locally, diabetes and obesity are the two biggest drivers, hand in hand. And to my surprise, cancer, HIV, other things that for other infections we typically think of are major drivers of bad outcomes have not really been major drivers. We've seen people do fine. They get sick, but not necessarily progress just because they have those comorbidities. But when you start piling it on, the more comorbidities, the older, the worse outcome on a population basis that we see. And that's really expected for many types of infections.
It's helpful to hear. And, I guess it's just one thing we all need to keep in mind is that, the people can respond very differently to this virus. Another puzzle that many of us have had, and it's certainly been discussed quite a bit in the lay media, is why different countries have experienced the pandemic so differently. Been lots of different theories and ideas out there, and I know no one knows for sure what explains these differences, but from your vantage point as an infectious disease specialist and running a major hospital, why is it that rates and outcomes in the US have been so much different, in many cases worse than those in other countries?
I think there are some local country specific issues. And I think then there's this uniqueness that is the United States. For example, island nations have a much easier time controlling their borders. So you can look at a New Zealand or a Taiwan, to some extent Japan. And they can control the influx much more easily than larger countries that don't have simple borders to close. But I would say that that actually is the superficial explanation. Countries, if you look at countries that got hit hard by the original SARS, remember in 2003, severe acute respiratory syndrome virus emerged in China, and it hit a lot of countries in Asia, including Southeast Asia, Taiwan, South Korea, including Australia and New Zealand, interestingly. Hit them much harder than it hit the West. Those countries, and I'll take a step back. The original SARS virus was much less transmissible than SARS-CoV-2, but it was much deadlier. On a per patient basis, a third of people who got infected by SARS died. We're looking at numbers of 3% or less, maybe as low as 0.5% for SARS-CoV-2. Imagine if the original SARS had been as transmissible as SARS-CoV-2. It would have been the worst pandemic in the history of the world. The countries that experienced SARS got scared. They realized they dodged a major bullet. They had deaths, but they could have been wiped out if it had been a more transmissible virus. So those countries developed very comprehensive pandemic plans. Look at what South Korea did with extremely sophisticated cell phone tracking technology, rapid rollout of tests. As soon as the virus appeared, they immediately identified everyone who had it and isolated everyone who had it and contained it up front, so it never permeated into the general population. The same thing happened in Taiwan. Vietnam did a great job as well. New Zealand did a fabulous job, and to some extent Australia. Countries that had experience previously adapted. We did not have that kind of experience. We did not adapt. What made things worse then, so we didn't contain, we didn't act early. And so we didn't stop it, so then it spread. And once it spreads widely, containment is done. You can no longer contain it, you can only hope to control it. We did not follow the previously established pandemic preparedness plan, which existed and was essentially thrown out. There was no national central coordinated effort. And essentially the feds deferred to local authorities. And so you ended up having, instead of one pandemic that you could have one central way to mitigate, you had 1,000 pandemics, depending on local municipalities, and no coordination. And even if one area did a great job, if it was flaring up in a neighboring county, it was going to spread. So I think we failed at initial containment. And then even when we lost containment, you could look at a country like Germany that didn't do a great job of initial containment, but did a great job of subsequent mitigation. We did not do a central effective mitigation strategy either.
All right, well, on the optimistic side, there's been some reports that outcomes with COVID may be getting a little bit better. And there's different explanations for this. And I'd be curious what your thoughts are. A, is this true that outcomes are starting to get better? And B, if so, why?
Yeah, I don't think there's any question that the outcomes are getting better. We actually started noticing that at the county hospital, in the county hospital system, a month and a half ago. It's actually been a while. Even as cases were increasing, the average severity was going down. If that had not happened, we would have been overwhelmed. Even, we got to the point where even with cases, the severity easing, we still nearly got overwhelmed. Well, that was what the proportion of admissions going to the ICU was falling. If that hadn't happened, we would have been overwhelmed in May. So why is it happening is the billion-dollar question. If you ask most people, they say, oh, it's obvious. It's because younger people are getting the virus. Yeah, that's not the explanation. That may play a role. That may be a factor. But I can tell you that we've analyzed the data. We actually have a manuscript that's been submitted to a journal looking at this question. And in the county system, there was no significant change in age. Now, that's probably in part because county hospitals tend to take care of younger people at baseline. Most community hospitals take care of an older population. We had an average age of around 50, 55 at baseline. And our current average age of COVID patients is still in that same ballpark. So certainly we're an example where clearly lower mortality, fewer patients in the ICU, but no change in age. So is it because the virus attenuated? Viruses are known as they spread through a population to have the potential to decrease virulence over time. We don't have any evidence of that either. People have sequenced viruses across many parts of the world, and there have been subtle changes found here and there, but none of them have been dramatic or linked to a change in actual virulence. So then you start asking the question, is it because of new therapies? And the answer is almost certainly no. We really only have one therapy that's been shown in randomized controlled trial to improve mortality, and the effect was rather subtle, and it really was seen in patients who were the sickest. What I'm telling you is that people are coming in less sick in the first place, before they even hit the door. Before they were coming in at death's door and going right to the ICU, much smaller percentage of them are going to the ICU now. So it's not treatment related. So the question is then, is it inoculum related? Are people getting exposed to smaller doses of virus at a time? And that would be my bet. And then the question is, why is that happening? Is it because we're wearing masks? Maybe. We happen to believe that there may be an environmental link, and we have data that we've evaluated that suggests a pretty good correlation between temperature and pollution driving severity. Colder temperatures, small particulate pollution was strongly associated with a much higher percentage of people in the ICU. So we may learn over time that there's multiple factors driving this.
What's really interesting, that's not one of the common theories that has been suggested in the media. I've heard a lot of medical professionals in particular, patting ourselves on the back. We're getting better at treating this condition, and maybe that is a piece of it. But I've also shared your skepticism that, especially with the data we've seen on some of these treatments, that really that's the explanation here.
Yeah.
So you mentioned this before about testing. There's been a lot of mixed messages about that. Certainly during a typical flu season, we don't test everybody for the flu, and testing doesn't necessarily make a virus or a disease better in and of itself. But other people have suggested that testing is a key part of the solution to getting us out of this pandemic and everything in between. And it would be very helpful to get your thoughts on where you stand on this issue.
Yeah, I think, Mike, one of the reasons you and I tend to get along is we're both centrists. And I think one of the tragedies of this pandemic is that it has become hyperpolarized, so that you're either this or that and nothing in between. And people spend a lot of time yelling at each other rather than stopping and thinking through the data and talking things through. If you have early testing at the beginning of the pandemic, so that you can rapidly identify people who are infected, trace all their contacts, and put all of them in isolation. And let's say you do that at a stage where there's 10 positive cases in LA County. Well, I could contain the virus. I have the person power to be able to say, all right, 10 positives, they each have 10 contacts. Yeah, I can do 100 traces in a day. When you lose that initial containment, and you've got 2,000 positives in a day, and each of them have 10 contacts, how are you going to trace 20,000 people in a day and isolate all those people? You can't. We don't have the person power. We blew containment up front as a country, and that left us with mitigation. Once you're in the mitigation stage, the purpose of testing is to identify people who are sick, and then to the best you can, get them to isolate. The role of testing asymptomatic individuals is not clear-cut. There are people in my profession that are screaming bloody murder, that it is clear cut. I simply don't agree. And I will tell you that in my debates with people verbally or on Twitter, 15 different people have 15 different reasons why you should be testing asymptomatic individuals. There's no clear cut whatever. Most of the reasons that I've heard are really not valid. So when I say, why should we test asymptomatic people? Well, we have to isolate them. You don't need to test them to isolate them. If they were in contact with a COVID patient, isolate them. I'm not going to take them out of isolation based on a negative test. Just isolate them. I only heard one valid reason from anyone to test an asymptomatic contact of a COVID patient. And that is that if the contact also tests positive, I might then test their contacts. Maybe I should do a second ring of isolation. And in a world of, how should I put this, unicorns, sugar canes, and gumdrops, that would be great. If I had unlimited person power and I could isolate 50,000 people in a day, that would be fabulous. But I can't. I don't have that person power. We could have done it if we got containment right, but we didn't. It's already everywhere. I have 2,000 positives a day. I can't be doing second rings. I can barely do the first ring. So my point really is, look, I hear you on that, but let's focus on the basics. Test people who are sick. When they're sick, isolate them, right? Get that done right. Get the mitigation, the hand washing, the physical distancing, the mask wearing done right. That's a much better investment, in my opinion, of time, energy, and effort than expanding testing to people where it's of questionable merit and benefit.
Well, I completely agree with you, Brad. And, the CDC's gotten a lot of heat recently for their changing of the guidelines, saying that asymptomatic contacts of those who have been infected don't necessarily need to be tested themselves. And I felt similarly to you, just because I've had my own patients that have had exposures, and we get the test and it doesn't necessarily change anything we do. We should be, as you said, isolating anyway, if they've had an exposure. So would you say you're sympathetic to the CDC's recent shift?
Yeah, so I mean, I guess I would say, one thing I worry about, and I actually would be curious about your reaction to, Mike, is I worry somebody's in contact with a COVID patient and I test them and I'm like, by the way, your test is negative. Are they going to respect the isolation? Is it going to weaken their understanding of the need for them to stay isolated? That negative test does not mean they're out of the woods. I worry about it weakening that ring around that first true exposure. I will honestly tell you that the majority of people who I spoke to who are ID doctors that were furious at CDC, when I confronted them and asked, explain to me, teach me why you think this was the right thing to do, the answer for most of them was, I think this all got political. And I think CDC got knuckled under by politics and they didn't explain why they wanted this done. And so it wasn't even about the science. It wasn't even about clinical medicine. It was about politics and partisanship. I think you and I, again, tend to live in the middle. It's like, this is not about who's in the White House or what they see. I don't care. I'm just telling you from a medical scientific perspective, I actually agree in this instance with the CDC's position, personally.
Yeah, I do as well. And I think, maybe there is a critique that they didn't communicate their rationale well enough. Nevertheless, it is a nuanced point that can't be communicated easily in a soundbite. And it's just easier to criticize them and say it was a politically motivated decision. Well, along the lines of testing everybody, as you've probably heard, there's a number of new testing technologies, antigen tests that are a couple dollars, potentially even like a home pregnancy test that people could buy at the drugstore and test themselves potentially even multiple times a week. Do you think if such a technology became available, it would be more realistic or feasible to do the mass testing that some have been talking about?
Certainly it would become more feasible if the testing was more widely available. I still think it leaves the question open of whether we should be doing that. I mean, society has to decide where to invest its energy, effort, and momentum. And I don't personally, I have a hard time envisioning a world in which we can manage ourselves out of this pandemic simply by testing everybody. I don't see a path out of this pandemic until we have a vaccine. And if we have a vaccine, the testing starts to become much less important. I would rather invest more energy and effort and resources into getting vaccines on the market, take them through phase 3 trials, show they're safe and effective, and manufacture them up and distribute them and get them to people. The tests all have variable accuracy, and perhaps more importantly, and this is something you simply don't hear people talking about, being positive in the test doesn't mean you're contagious. None of these tests measure infectivity. None of them have studied, none of them have shown, have even attempted to evaluate a link between being positive and being able to transmit the virus to others. And there are lots of reasons to believe that those tests don't predict infectivity.
Well, I agree with you. I mean, I think of all the things that we could be investing our resources and effort in, I certainly would like to see some of those public health, simple public health measures like masks and hygiene and surface cleaning get more of the attention than some of these issues like testing that may have less value. There's also an antibody test that will theoretically tell patients if they've previously had the infection, but we've also learned that there are a number of problems with this test. Is it possible for anybody to know with the antibody test if they've previously been infected?
So I think there's several different antibody tests out, and I think we'll see over time which one tends to perform better than the others. And I do think, generally speaking, for most types of infections, after study, we are able to land on a couple of different types of antibody tests that will tell us you've had past exposure to this pathogen. You're not currently infected, but we know that you've been exposed to it in the past. I do think that is, I would expect that that would be the case over time.
So if testing wasn't a controversial enough topic for you, I'd love to get your thoughts on children and COVID. And initially we heard a lot that maybe they don't get COVID, or even if they do get it, they may not transmit it. And opening schools, therefore, would be a safe thing to do. But some of the more recent studies have suggested that not only do kids get it, but they may also transmit it to others. What's your take on where things are with that question right now?
Yeah, I think that kids are less susceptible to severe COVID, not to say immune, but less susceptible to severe COVID, but they definitely get COVID and they can definitely give it to others.
So even if they can get it, there was a recent report from Rhode Island which found that as long as simple protective measures are taken, like screening kids when they come in, wearing masks, certainly having the adults wear masks, doing a really good job with cleaning and hygiene in these daycare facilities, that we could pretty effectively prevent the spread within these facilities. And I think they found that it was only about 1% of the facilities in Rhode Island that reopened following these measures experienced secondary spread. Does that give you hope or optimism? And I'll say this as a parent who has little kids and got to keep them busy. So I do have a personal bias and stake in this one. But does that give you optimism that that is possible or safe to do?
I'm skeptical. People are imperfect beings, and to be able to sustain something like that, it only takes one error for there to be, pretty serious consequences. This is not going to be a forever pandemic. And we're going to come out the back end of this at some point. And it is a once in a century event. For me, again, I would rather invest in basic public health measures and vaccines, and invest in the economics and technology to allow remote learning and remote, business to occur. As a parent, I don't want my kids going to school till this is done. And I am puzzled. And I'm not to say that there isn't an alternative view. I get it. A lot of people are like, no, my kids need to socialize. And I'm like, they can't wait a year. They can't take 1 year off of socializing and do remote socializing for a year. We're going to get through this. And instead of investing in very labor intensive and expensive means to deliver what is an uncertain product, would it be better to invest in the technology and the economics to allow remote learning and remote businesses to run?
Well, it's funny, I've actually appreciated some of the benefits of taking a break from socialization, but my wife has missed it a lot. So I think some of it may come down to just people's personalities and how much they are anxious to get back into it, because I agree with your perspective there, Brad. This week there was some concern raised because there have been a couple cases now, one in Hong Kong and another one today I just saw in Nevada, of apparent cases where people got reinfected with the virus. Is this something that should cause us alarm?
No. The simple answer is no. There is no such thing as an infection that cannot reinfect. Probably the closest thing we know of is measles. Measles is often sort of said to be perfectly protective. That is, you get the first case of measles and you cannot be reinfected. But we know that that's not true. We know you can be reinfected from measles. We know it's very rare. But let's say it's 1 in 1,000. Let's say that the initial case protects you by 99.9%. Okay? There have been 16 million COVID cases in the world. Even if it was 1 in 1,000, there should be tens of thousands of reinfection cases. I actually am greatly heartened by this. We have 2, maybe 3, maybe 5 now likely reinfected cases out of 16 million. That's fabulous news. That means that herd immunity will work and that a vaccine is very likely to work. I actually think this is very encouraging.
Well, that's good to hear. And I feel similarly, but I've also heard people who get anxious when they hear these reports. So it's good to hear an expert say that to us. On the treatment side of things, Brad, there's been a tension between the need and desire to get new treatments rapidly to people who need it, new vaccines rapidly to people who need it. I think this was highlighted recently by the case of convalescent plasma, where some folks felt that it wasn't quite ready for prime time. First of all, what is convalescent plasma and what's the controversy around it?
The first truly effective treatment for lethal bacterial infections was something called serum therapy. And this goes back to the late 1800s, 1880s, 1890s, where scientists who later won the Nobel Prize would immunize horses with bacteria. And they would bleed the horse, take the serum from the blood, and infuse it to people with those infections, and they would get better. The reason that works is because the immune system of the horse, or for us, the immune system of people, generates antibodies. And these protein antibodies bind to, kill, or block the pathogen, in this case, a virus. So we've known for 130, 140 years that what you're referring to as convalescent plasma is a potential treatment for various types of infections. So the way this works is somebody gets COVID and they survive. Their immune system presumably makes antibodies to the virus. We take blood from that person. We take out the plasma component of blood, which is where the antibodies are, and we infuse it into other people. And people have been very optimistic that this might be a viable therapeutic based on the serum therapy experience from other infections 100 and some odd years ago. Unfortunately, the one randomized controlled trial that's been done of serum therapy did not show a benefit. Now, that's one trial of a very specific population of patients, and it was a small study, so it wasn't quote unquote powered adequately. In other words, it might have missed a small signal of benefit because it didn't have enough people in it. It doesn't mean that serum therapy won't work, but it does suggest that serum therapy is not going to be a game changer if it does work.
And what is a randomized trial? How is that different, Brad, from some of the other studies that have suggested a benefit?
So you can correct me or add. Generally speaking, we can dichotomize clinical studies into one of two types. Those that suggest something that we call hypothesis generating. Hey, a signal is seen. I wonder if that's real. And those that confirm the signal is real. Hypothesis generating, hypothesis confirming. The studies that you're mentioning that are non-randomized are all hypothesis generating. They're all subject to many different types of bias that preclude you from being certain when you see a result that it's real, as opposed to it's a correlation with something else, but you don't know what that other thing is, and it's not a real signal. The power of randomization, especially in a blinded setting, and that's an important point because there are other studies that are randomized but unblinded, and they have their own problems. The power of a blinded randomized controlled trial is it eliminates those biases. So if you see a signal, it is caused by the intervention, the treatment that's under study. The one randomized controlled trial of convalescent plasma did not work. Other non-randomized studies suggested benefit. Those are all hypothesis generated. And we cannot rely on them to tell us that it actually works. And please, I actually would like to hear, you're the expert here, Mike, give me your thoughts on this.
Well, I couldn't have said it better myself in terms of the difference between a randomized trial, which quite simply is just a higher quality, more rigorous study that we can trust compared to some of these observational, lower quality studies. There's a part of me that is sympathetic, that wants to get a new treatment to people sooner, faster. But in this case, I do think the FDA overstepped by providing the emergency use authorization. I think the risk there is that now there's going to be less of an incentive to do the rigorous studies that are going to prove whether this actually works or not. And we could get tricked and can actually delay the pace of therapy. But as you said, there's counterpoints to all of these things. And, I hesitate to second guess every decision that these regulators are forced to make.
Other potential therapies have been subject to various types of studies. And one of them that has been successful is called remdesivir, which is an antiviral agent that's gotten a lot of press and is making a ton of money for Gilead, the company that sells it. And remdesivir was quote unquote effective in 2 randomized controlled trials, but they were unblinded trials. And the definition of success was subjective. They were not successful on mortality. They were not successfully shown to reduce death. They were shown to reduce the amount of time it takes for a doctor to turn off a patient's oxygen or discharge them from the hospital. And you know, because you practice in the hospital, Mike, how subjective it is when we say, yeah, I think I'm comfortable today turning off the oxygen, or today I'm comfortable discharging this patient. If I know that patient has been on the therapy, my judgment is absolutely likely to be effective as compared to I know that they got placebo. I think that that's a really important limitation, and I'm really disappointed in the scientific, the biomedical community for not holding these COVID therapeutics to the same rigorous standards that we were holding drugs to before COVID came along.
I think that's absolutely right. I mean, I think under normal circumstances, there's not a prayer that remdesivir would have passed based on those methodologic limitations, the scrutiny by the FDA. And it also gets to the point you made before about investment of resources, the amount of bang we get for our buck with a very expensive drug like remdesivir that may or may not slightly reduce hospital length of stay versus some of these other public health measures that are essentially free to do or very cheap and may have a really big population health benefit there. And I think, when the first vaccine studies start to come out, I think there's a real important need for people who can hold the FDA and other regulators honest, because a lot of us are going to be just so anxious to get something approved and out there, and it could actually backfire if we don't follow our usual rigorous academic standards.
Yeah, absolutely. This cuts, but let's hold to the science. Let's not politicize this. Let's not be hyper-partisan. I'm not going to yell at the CDC over a decision they made that I think is scientifically sound, but I am going to, on the same coin, I'm going to say, FDA, if you're going to let vaccines onto the market without conducting rigorous phase 3 randomized controlled trials, we have a problem. I'm not going to know if this stuff works. This isn't politics. Get the science right.
So, Brad, this brings us to another topic that I really want to talk about with you, which is your new book, Broken, Bankrupt, and Dying, which I guess is another side hobby that you and I have, which is figuring out how to make the health system and healthcare system run better. And it was an incredibly thoughtful book that really is an indictment of how our healthcare delivery system works, how we're the most expensive nation in the world for providing healthcare, and yet do not get even good outcomes compared to many other countries. How would you describe what inspired you to write this book and what your main thesis is?
So this book was therapy for me. No, and you see it because you work in this same hospital, that our patients get crushed by our healthcare system. And I'm not talking, the county system is great. I'm talking the US healthcare system, the system that traps them without insurance or puts them on Medicaid and traps them in networks. Or they have private insurance and they come to us and they want to be seen by us and we can't see them because they're out of network, they have private insurance. The system that causes 500,000 medical bankruptcies per year in the United States. The system, as you say, that causes us to spend 2 to 2.5 times more per person or per GDP than peer nations, but live shorter lifespans than those countries. That system is crushing families and it's crushing patients. And frankly, it's crushing our colleagues. We have an epidemic of physician burnout because of the ridiculous paperwork and bureaucracy burdens of our healthcare system, none of which is necessary. That was really the motivation for writing the book.
Now, I think you wrote this book, or at least started to write it, Brad, before the COVID pandemic hit. Do you think our response to COVID has been at all symptomatic, or any of the underlying problems that you talk about in this book have been exacerbated or highlighted by this pandemic?
Yeah, that's another fastball right down the center of the plate. Thanks, buddy. COVID has stripped the veneer off of the US healthcare system and exposed the rot within. We are really the only country in the world that links explicitly healthcare access to employment. You get your health insurance to your job. If you lose your job, and 40 million Americans have filed for unemployment, where's your healthcare access go? There's no reason for that to be the case. And in fact, as we talk about in the book, that was not a rational plan. No group of people sat down and said, we're going to design the US healthcare system around employer-sponsored health insurance. That is an accident of history. Our system exists because of 2 laws passed in 1942 to raise the funds to fight World War II and combat post-World War II inflation, not to deliver healthcare. Other countries throughout the world have rationally designed healthcare systems, and they work much more cost effectively and effectively than ours. And we can learn from those models to redesign our system.
There was an article last week, Brad, in JAMA by Josh Sharfstein, who was a former commissioner at the FDA and Baltimore public health commissioner. And it highlighted the fact that health insurance companies have actually profited tremendously because of the COVID pandemic. And the reason is quite simply they are not paying for elective procedures the way they were before. Does this surprise you, and what should be done about it?
So we talked about how you and I are both centrists. The central thesis of the book is that the reason why our healthcare system doesn't perform well is not because of evil doctors, evil hospitals, or evil insurance companies. It is because the system itself is not intelligently designed. It was, in fact, never designed. Insurance companies in a capitalistic society have a mission to make money for their shareholders. That's their job, right? Courts in the United States have ruled that it is the responsibility of the directors of a for-profit company to help that company earn money for its shareholders. How does an insurance company make money? By receiving premiums from people who don't need healthcare. They sign up healthy people. They make money on healthy people. They lose money on sick people. That's how the system works. We have a fee-for-service healthcare system in which hospitals make money by getting people super sick, so we put them in the hospital and do a bunch of surgeries on them. And insurance companies lose money on those same patients. So they're malaligned. The patient's interests, the physicians' and hospitals' interests, and the payers' interests are all malaligned. They're not working towards a common goal. It is absolutely financially to the insurance company's advantage for sick people to lose their health insurance, because then they don't have to foot the bill for the care. We need to redesign our healthcare system so that the interests of the patient, the provider, and the payer are all aligned.
Well, I appreciate the way you put that. In fact, in the medical error literature, it's a very similar philosophy where we can't blame individuals for acting the way that the system sets them up to act. And we really need to fix the system problem. And I think exactly as you said, this is emblematic of a larger system problem, and people are just acting the way the system incentivizes them to do so. Along those lines, you use a term in your book called Johnson rods. Tell us about it.
All right, so you used to watch Seinfeld, yes, Mike?
Of course.
Of course. And I'm sure many of your listeners did as well. So there's an episode of Seinfeld where Jerry irritates Putty, the only honest car mechanic in town. And of course, he then gets car trouble. So he takes it to another shop, and they call his house, and he answers the phone, and he says, $2,500? Don't do anything. I'm going to think about it. And George says, what's to think about? If Putty says it's $2,500, it's what it is. He's not going to rip you off. Yeah, but it's not Putty. Well, what happened to Putty? Well, he got irritated at me. I had to take it somewhere else. I think they may be trying to screw me. Well, of course they're trying to screw you. That's what they do. They could make up anything. Oh, you need a new Johnson rod in there. Oh, a Johnson rod. Okay, I guess you got to put one of those in there. This was, to me, when I saw this episode as a rerun, as a physician, I'm like, wow, that's what our patients go through, right? I hear this all the time. The problem with US healthcare is the lack of price transparency. Really, is that the problem? Your patient and their family, when you say, you know, I think I need to prescribe Zosyn and linezolid today, they're going to go, oh, you don't need to put Zosyn and linezolid into me. Just give me some amoxicillin. If you tell them they need surgery A instead of surgeries B, C, or no surgery, they're going to know based on price transparency. No, that's a Johnson rod to them. They have no way of knowing. They don't have the expertise. It's asking a lot of patients and families to be able to dialogue with the physician to that level of sophistication. But in a fee-for-service environment, the doctors are incentivized to put Johnson rods into people. And I don't want that from my doctor. And I don't want my patients to think that's my motivation when I'm talking to them. That's the Johnson rod analogy.
So what's the solution?
We need to get rid of the fee-for-service mechanism for funding healthcare in the United States. Part A. And part B, we need universal healthcare. And those are two interrelated things. Because if we have a universal healthcare system, we can change the payer mechanism so it's not fee-for-service, so that it's globally budgeted, so that the incentive is, I'm going to pay you to keep this person healthy so they don't need to go in the hospital in the first place.
Well, I'll just recommend that if anybody really wants to understand what is wrong with the healthcare system and how to fix it, this is a great place to start. Broken, Bankrupt, and Dying. And Brad, could I just ask you where listeners could get the book?
Amazon.com.
Very, very good. Well, Brad, this was a great discussion. I so appreciate your taking some time out of your busy schedule to join us today. And good luck taking care of patients. And maybe we'll even have you back on as the pandemic continues to shape up. Thank you so much.
Thank you, Mike, and look forward to it. Take care.
So that will do it for the inaugural episode of the Healthy Skeptic MD podcast. A big thanks goes to Dr. Brad Spellberg for enlightening us about the COVID-19 pandemic. If you liked what you heard today, subscribe to the Healthy Skeptic MD wherever you listen to podcasts, and we'll do it again next week. Take care.